All right, let's go ahead and just get started. The ones who aren't here, that's on them, and they can filter in as they can. Um, so, what did you guys think about the midterm? I thought it was too easy.
Yeah, it wasn't bad.
No, it was not bad. Like I said, a lot of it was should have been familiar to you from the first test. So that was and something that I'm trying to do, guys, and it's for a reason. You know, these questions that I put on here, I put a few on both tests so far that really you can't miss. Um, but I want you guys to think about this stuff. And, you know, I ask, like, what recreation therapy setting would you like to work and why? You know, things like that. You can't give me a wrong answer on that. That's just, but I want you to be thinking about things that impact your future. And some of the questions that I put are going to be just to get you to think, where you can plan ahead and start moving the direction you need to go. So, I have thought about possibly changing the format on the, you'll have two more tests. Thought about possibly changing that format to, you know, all automated, all multiple choice, etc., like that, where basically I won't have to go through and check every one of them. I don't mind doing that at all. But I think that if we do that, we'll lose a little bit. I kind of like a few of the discussion questions because it shows me whether or not you really know what you're doing. And it shows me the ones who are going to put out a little effort and who is not on in some cases as well. So again, if we continue with this route and we have another test with discussion type questions, put something there. I still had a couple people leave some things blank. Don't do that. That's just throwing away points, because I don't know if you've gone through, but on a lot of the questions I've, you know, I try to respond back to you when I'm grading them. I will do my best to give you partial credit on anything that I can deem as being worthy. So that's kind of the way I look at that. I don't put those on there to be hard, but the ones that are actually asking for content, be sure to watch for things like, if I ask you to give an example, be sure to give a specific example, not just tell me like the definition and not give an example, because I can't give you the full points on that. But anyway, I'm not going to take the time today to go back over that test, because there really was a lot that was from the first portion. If you guys have any questions or anything as you're looking over it, y'all can email me things. You can check back on your tests. They should all be, I think everyone that took it has been graded at this point. So y'all can reach out to me if you have anything, but most of you did very well. I had a couple people that got all 150 points. So it's definitely there to be, you know, to be had if you apply yourself on the test and do a little bit of prep for it. So at that point, now we're just going to jump right on in back to where we finished off last time and finish out this chapter that we started talking about people with developmental disabilities and how we can serve them as recreation therapists. So let me share my screen and we're going to start the screen sharing back and forth to videos and me talking again. Let's see. All right, y'all should have a PowerPoint now. So this is the one that we ended on. Just in case I was kind of losing you guys at the end, let's run back over this real quick. There's different types of cerebral palsy. This was the last thing that we covered. Spastic is the most common form. That's where people really have super tight muscles, super stiff, jerky movements, not a lot of control at all. That is because it's the most common, that's the cerebral palsy that most of you would kind of think of when you think of cerebral palsy. There's 3 different forms, and know the difference between these. Diplegia is when only the legs are affected. Hemiplegia is half of the body, so the right arm and the right leg, or left and left. Quadriplegia, you've got both arms and legs being affected. Athetoid or dyskinetic, that's just the opposite almost of spastic, where they have super low muscle tone and their movements are uncontrollable and slow. Ataxic cerebral palsy has a lot more to do with balance. They have a poor sense of balance. They can't control their muscle length or position. So just like I used as a reference last time, if they're reaching for an object, they're liable to overshoot. You know, if they're trying to pick up a cup, they very well may knock the cup over. So you may not want to sit across the table from someone who suffers from ataxic cerebral palsy at the dinner table. You might want to make sure that you're not directly in front when they reach for their cup. And mixed is obviously just a combination of the above types. It would be kind of hard to have a mixture of spastic and athetoid, being that they're almost opposites in their main ways that they present themselves. So some characteristics, it's going to range from mild to severe. You know, a mild case, you're still able to function at a higher level. Typically is going to affect locomotion, which is just your walking, gross and fine motor coordination, and your communication. It does really come into play a lot of times in communication. The muscles that are involved in speech are affected just as well as other muscles in the body. So that's where the communication issues come in. There's also, you know, several of these developmental disabilities we've talked about, they have seizures as kind of a side effect almost. There's a higher incidence of seizures in comparison to the general population when you're talking about people who have cerebral palsy. One thing that we think about when we do activities with our patients or clients, you know, we try to get them active and to do as much as they can. But if they overexert themselves, for someone with cerebral palsy, their sensation, vision, and speech, they can all worsen if they overexert. So something to think about when we're working with them. Because of the problems with coordination and locomotion, a lot of times individuals with cerebral palsy, they're not as active as we would normally be. Obviously, if you're in a wheelchair or a walker because you have trouble getting around, you're not going to be as active as you or I would be. So you're looking at a higher risk of obesity due to inactivity. So as far as therapeutic recreation with these clients, there are some things that we work with specifically. There's some pathological reflexes. You know, this is caused by brain injury. It can be, you know, during childbirth even, but brain injury is generally a cause for cerebral palsy. They have asymmetrical tonic neck reflex triggered by head movement, where if they move their head certain ways, they have one side have their head basically turn one way and they're unable to move it back. You know, they kind of get stuck. So if we work with them and develop motor skills in general, other motor skills, and work on training the body, then it can somewhat inhibit these pathological reflexes like the one, you know, the tonic neck reflex. They may not have as much issue with that with the more activity that they get and the more their body is kind of trained to work in a more effective manner. They have imbalances in the engagement of flexor and extensor muscle groups. You know, flexion is basically bending the arm up. Extension would be straightening it out. So you've got different muscle groups that do those two things. And you can reduce imbalances with massage, stretching, trunk rotations, warm water aquatic programs. Again, I told you this is a group that I really enjoyed working with. When I was at the regional center. Um, Buoyancy makes movement easier for them. It also helps to release some of the spasticity if they are dealing with a lot of tone and spasticity in their body. Some things that are used, popular modalities, and we all know what modalities are now, right? That's just the different therapeutic recreation tools that we use. Popular modalities, therapeutic horseback riding and hippotherapy, which are basically the same. You're not riding a hippo or using a hippo. They're both involving horses. Therapeutic horseback riding is more, there's a difference between therapeutic horseback riding and hippotherapy. And the difference is that therapeutic horseback riding is more about enjoying being around the horses, about, that you spend time grooming, it's relaxing to be around the horses, and you kind of ride just for fun. Hippotherapy is actually something that's very interesting. When you are on a horse and riding a horse, what happens is, well, number one, and when you're sitting up there, you have to maintain trunk control, which is difficult for some people with cerebral palsy. Something else that is pretty awesome, when the horse is walking, you're going to be going back and forth on the horse, your pelvis. It moves your pelvis basically exactly the same way that it would move if you were actually walking. So the pelvic movement is very much similar, almost identical to you walking when you are sitting on top of a horse. So able to get that work with the body with people who have cerebral palsy, it's almost like, that would help for you to do like a walking program with them in water. Them doing hippotherapy would help to work muscles and loosen things up that would allow that to be more therapeutic and work better for you. They actually have a really good hippotherapy program at the NMRC. It's been going for several years, and some of the ones that they definitely have involved are clients that have cerebral palsy. Pretty fun to help out with. Okay, the next thing that we'll talk about is spina bifida. Spina bifida is a situation where the spinal column doesn't close all the way during gestation. A portion of it is still exposed. And what interesting note is 40% of Americans have some form of spina bifida. And that's way higher than I would have ever thought. And I never would have realized that prior to looking into this stuff. Now, that's some form of spina bifida. It can be just a very, very, very slight case that will not affect you one tiny bit. I actually had a scare with this in my life. My oldest son, when he was born, it's almost kind of funny, but on his lower back, just right above his butt crack, he had a patch of hair, probably 2 or 3 inches long, and it was pretty hairy when he was born. And I was like, Jesus, does he have a tail or what's going on? But ended up not being a tail. He just had a little fur there. But that is a sign of, like, when you have a spot on the spine in a child when they're born, a lot of times where the hair is, it will also can look irritated and things like that. That's a sign of spina bifida. And he's got absolutely zero issues, but I would be willing to bet, my paycheck that he is in that 40% that has some form of spina bifida. He's had no issues whatsoever so far. Nothing has been diagnosed, but he definitely has that little spot. And he's 7 now, and he still grows hair there. So I get clippers and cut it off where he won't be the weird kid with the fluffy spot on his back. So not that all the other kids are seeing his back right now, but anyway, let me get back on track. I'm sorry. anyway, 90% of people who have spina bifida live a normal lifespan. So it's not something that necessarily is going to cut down on your length of life or anything like that. It's classified as an orthopedic disability, and sometimes they classify it as developmental because of early onset. You know, this is something that you're going to find out early. You know, you're not 30 years old and all of a sudden find out that you have severe spina bifida. You know, you're going to know it prior to that. You're going to find out early. So it's an orthopedic disability because it affects your spine, which is obviously orthopedic, and it's developmental because it's an early onset situation. So there's 3 types. We'll talk about these 3, and then we're going to watch a little video. Spina bifida occulta. It sounds bad. Occulta sounds to me like a mean word, but it's actually the mildest with no symptoms. There can be 1 or more openings in the spinal column. You guys need to know the difference between these 3 types of spina bifida. There's also meningocele, where there's a sac protecting the spinal column. It actually gets pushed through the opening. It's like a bulge, and that can be repaired. And it's you know, that's more serious than not having, you know, that's more serious than the spina bifida occulta. It does not have a bulging situation or anything like that. Meningocele can be repaired. And then there's myelomeningocele, and where that is, the spinal cord actually protrudes through the back. And this is what is, when people identify something as spina bifida, it's this myelomeningocele. Because the other 2, the first one you probably won't even know. The second one is repaired and generally has pretty low symptomology after that. But the good news is that this happens in fewer than 1 in 1,000 children, so it's not an extremely high prevalence. The symptoms are muscle weakness or paralysis below the exposed area, you know, just kind of like a spinal injury. Wherever you have this protrusion of the spinal cord, that's below that is where you're going to see the symptoms of spina bifida, which are like weakness or paralysis below the area, loss of bowel and bladder control, hydrocephalus, which is the swollen head, or water on the brain, it's called. 70 to 90% of the cases that are in this myelomeningocele have hydrocephalus and require a shunt to bring down that swelling in the head. All right, so let me click this. Stop share. Stop that. Bring it back. Back to you guys. Share the screen. I about got this stuff down now, I think. All right, 3 minutes and 13 seconds.
My name is Amelia Murphy, and I'm 10 years old.
I'm Pam Murphy, and I'm the mother of Amelia, Claire, and Emma Murphy. Amelia has spina bifida. She was diagnosed when I was 19 weeks pregnant. We were able to get a lot of education under our belt before she was born. We had specialists lined up. So she has spina bifida and lots of other extras along the way. She's had 60 surgeries in 10 years, and 57, I'm sorry, I was wrong, 58. She's had close to 60 surgeries in 10 years.
I've gotten pretty used to it. Some of it scares me, some of it doesn't.
We moved to Cincinnati about 7 years ago from Washington State. So we needed a hospital that was in the top 10, preferably in both neurosurgery and urology, and had a multidisciplinary clinic for spina bifida. And Cincinnati had all 3 of those and a good cost of living. And I'm from the Midwest anyway, so Cincinnati won, and we moved here and have not been disappointed. We love it.
I cheer, I dance, I play soccer, a lot of my classmates ask me, why is your hair gone? Do you have cancer? Did you have something done? And to that, I say yes. I had surgery done on my head, and they had to shave my head. Sometimes it's a little bit hard, but most of the time I'm fine with it.
Last spring, she had 5 surgeries in about 6 weeks. It was a pretty tough time. And when it was time for her to go back to school, her whole head had been shaved and there were 4 different incisions on her scalp. And so it was a pretty significant change. And I wondered what she was going to think about going back into a 4th grade class and seeing all her friends. And so we talked about that. And her first concern was, is this going to scare my friends? What can I do so that they're not scared? So even then, she was thinking about them first before she was thinking about herself. She's an inspiration, I think, not just to our family. She certainly is to me. When I come home and I've had a tough day at work, I think about how it could be a whole lot tougher. You never know where things are going to take you. You may get really horrible news one day and find out 10 years later that you have the most hilarious, amazing kid in the world, and you're all so much better for it. I can't imagine our family being any happier at all.
All right, so are you guys having a bad day or not? Because she had 57 surgeries. It kind of puts things into perspective, you know. That's a tough little girl, and you know, you see in a lot of ways she doesn't miss out on as much as you would think she would. You know, she says, I play soccer and I do things with my friends, and I think that it's awesome of how, you know, she said, the mother said that she thought about her friends first, you know, like, is it going to upset them when I come back with my head shaved? So it's pretty awesome. You know, same situation we're seeing, and in almost all of these videos, you have parents that, you know, they get this diagnosis that's, you know, this awful news, this awful diagnosis, and then come to find out, they end up being the biggest blessing that they could have. So kind of cool story and all to me. Let's go back to the PowerPoint and we'll move along. First, what do you guys think about the videos so far? Are they pretty good? I mean, it's making the material take a little longer, but I think that it's something that, you know, like I say, this chapter, the next chapter, several of these, we're into the point now that we're talking about specific groups that we can work with and who we can help. And I wanted you to see, because some of you haven't had the opportunity to work with, you know, people with developmental disabilities. And of course, they're not the only group that we can help and work with, but they, you know, some people are kind of scared, you know, like, you're scared to work with them. It's like you're going to catch it or something, but it's not that way. You know, most of the time it's a really, really good experience. And like I say, I really wish that we had the opportunity to do Special Olympics this semester, but it didn't work out. That would have given everybody a chance to work with some of these populations and, you know, get a feel for, hey, they really are a lot like me, you know. But anyway, in the future, if you ever get a chance to help out with Special Olympics, don't not do it if you have an opportunity to do it. It's something that I think that you would really enjoy, even if you think right now that you wouldn't. By the time you got there, if you let yourself get involved, you have a good time with it. All right, enough rambling on that. Let's go to the next part. Yeah, Special Olympics is one of my favorite things that I was involved with when I was working at the regional center. That's where it all started. And I worked with Special Olympians for, gosh, almost 20 years. And now I'm going to be the contact here at the university for Special Olympics. So when we have a event or something here, I'll be the one that'll be their contact point. So I'll definitely know when that's coming and all that. All right, so with spina bifida, what kind of therapeutic recreation are we looking at? Some of the goals, we look at trying to improve muscle strength and flexibility. We have to think about the fact that some activities may have to be adapted. Obviously, you know, right when she said on the video, I play soccer, she was playing wheelchair soccer. And that's great. There's nothing wrong with that, but that's an adaptation of an activity. And that's where the personalization or individualization of these program plans comes into play. Everybody is going to need a little different adaptation. And we want to work on esteem, self-esteem, and empowerment. You know, that's why when we talked about goals and objectives, I talked a little bit about how we want to set goals and objectives that are challenging but attainable. If something challenges you, yet you still reach your goal, then you're going to feel empowered and you're going to feel like, yay, I did it. You know, I can do these things. Your self-esteem will go up. And that's something that's learned through time, and it varies with each person that we work with. But it's try to find that balance between the amount of challenge necessary to make it empowering and making it so hard that it can't be attained. Some things to watch out for with spina bifida. Here we go again with the seizures, possible seizures. It's more common than in people who do not have spina bifida. Swallowing difficulties, so choking can be an issue. A lot of times there's cognitive impairment. You might have brain damage from the hydrocephaly we talked about. Neck pain, we talked about how the neck, it could have had some damage from the time when the hydrocephaly was there, and also some of the spasticity and reflexes where the neck just goes extremely tight. Apnea is another. Some breathing difficulties. Bowel and bladder infections are also common. I don't really know why that would be something that would be more prevalent. Maybe because of, you know, less movement in general, you know, to help the body move things around and flush out toxins and things. That could have something to do with the increase in possible bowel and bladder infections. Okay, we'll move on to muscular dystrophy. It's a group of chronic genetic diseases where you see progressive degeneration and weakness of voluntary muscles. So this is one that starts and progressively gets worse. So this one is a little bit sad. You can actually see the decreases in the ability to use voluntary muscles and move the way they want to, and they're unable to do some of the things that they were able to do at one point. You know, that's where we as recreation therapists can help. Now, there is a progressive degeneration. That means it's going to get worse. However, if we focus on the things that are getting worse, we can slow that degeneration down, maintain their quality of life for longer, and make it better, you know, along the way. Slowing it down, keeping them where they are is absolutely a success. You don't have to be building muscle. If you're keeping them at the same strength that they already are, you're successful in working with this group. Where it comes from, it's hereditary, or it can be a mutated gene on the X chromosome. As far as therapeutic recreation, you want to do activities to improve movement, work on flexibility, and again, you have to adapt activities for participation. That's important and something that really does come into play when you're working with special populations like this. So let's go to this video. Oh, they removed it. Y'all missed this one. Not sure why they would have removed that one. Maybe it was some sort of copyright situation. All right, we'll just keep trucking along. So here's some more things that you need to pay attention to and know. You need to recognize this name here. There's types of muscular dystrophy, and in early childhood, Duchenne is the most common type. It accounts for over half of the cases. That's the most common. You need to know that. It occurs in 1 in every 3,500 births. It's the most aggressive type of muscular dystrophy. The signs become noticeable by age 2. So by or around that age. By the time that they are age 12, they are generally going to be in a wheelchair and usually die in their early 20s. So really, really sad. And you know, this is a situation where you have a child that you may not know that anything is wrong at all. And, you know, then they get to be around 2 and you start seeing these weird signs. Next thing you know, they're 12 and in a wheelchair. So whatever we can do to help them and make them happier during their time here is a bonus, you know. Some other types that are found during early childhood, and I'm not as worried about these because they're not as common. You need to know about the Duchenne and about the when signs show up, that they're wheelchair bound by about 12, and early 20s is when they usually will die from the issue. Some other types are Becker, congenital, and Emery-Dreifuss. There's some other types that show up in later childhood and even into adolescence. Facioscapulohumeral. You should get extra points if you can spell that, say that, whatever. That's quite a word. And then limb girdle. Those are 2 other types. The main one I want you to focus on is this Duchenne and the stats on it. So best practices, that's just as therapeutic recreation specialists or therapeutic recreation workers, what can we do for people who have developmental disabilities? We want to always promote leisure and let them know that it's an important part of their being, that it's something that they can get benefit from, and that it's important, you know, promote the importance of leisure. We need to be able to do activity analysis. We talked about that in the previous material where we're breaking down what things you need to be able to do to perform specific activities, you know, whether it's hitting a tennis ball, whether it's, you know, walking, you know, what steps would you have to do to walk? You have to be able to, you'd have to stand up and try it to think of all the things you'd have to be able to do. You know, bend the knee, flex the foot, lift the leg off the floor, swing the hip, all the different things, but you break down the activities, and that way we're able to say, okay, can they do this? Can they do the next step? Can they do the next step? How can we work to help them do that? And then if it's something where that's where you see whether you need to put in modifications to help them be successful. So that's the importance of that. A lot of times we help psychologists and other people with behavioral modification because these developmental disabilities we're talking about, a lot of them are going to have intellectual disabilities that go right along with it. And that comes with behaviors that are not necessarily appropriate a lot of times. It may be tantrums, it may be self-abuse. You know, I worked with clients that when they got mad, they would poke themselves in the eye. Okay, I wouldn't do that. I know better than to do that. I would not do that. But for them, that's their way of, hey, I'm pissed off. This is what I'm going to do. And you start learning that that's what that means, you know. So you try to come up with ways along with the other people that are working on the interdisciplinary team, other departments that work with these clients, to help modify behavior to more appropriate ways. There's different ways to communicate for different clients. There's different ways of instruction. Some people really need hands-on. You know, they may want hand over hand to show them how to swing a tennis racket. Some people, the autistic clients we talked about earlier, they really wouldn't want you to touch them. They would much rather you show them and talk them through it than for you to have be that close to them in their personal space and touching them in most cases. So remember, there's different ways that you're going to communicate with your different clients and different types of instruction for the different groups as well. Same thing does not work for everybody. Again, here's this thing that we've seen before, at least twice on the test now, and least restrictive environment. And the reason it's there is because it's super important. We want our clients to be as independent as possible, to have the fewest number of modifications as possible, to do things by themselves as much as they can. Everything that we do for them that we shouldn't do is something that is holding them back and probably making them feel worse about themselves. So we want to support them, give them the things they need to be as absolutely independent as they can be. That's the key to least restrictive environment. And then leisure education, whether it is teaching them how to play checkers, how to play chess, how to play dominoes, how do we score darts, what sort of leisure is available to me, even though I live in a group home setting. Are there any free leagues for people in my age group? You can tell them what is available, how to get there, how to teach them the rules, teach them how to be involved in leisure. And especially if you're in a situation where, I'm sure I brought this up before, but if you're working, say, in a substance abuse setting, you know, you're going to have these people short term. They're there for rehab, detox, and they're going to leave your care. And through leisure education, this is a setting that I think is very important to do that, is you're teaching them things, reminding them of the things that they've replaced with drugs and alcohol and such. What are the things that you used to like to do in your free time before you started doing this? And you bring that back up, reintroduce those things, and you try to put that out as a replacement option when they get back out on their own. So you're setting them up as well as you can for success. Now, I'll say from personal experience, I used to consult at a rehabilitation center, and they can only be there for a certain amount of time based on like Medicare, Medicaid, insurance rules. So they'd be there for a certain amount of time. You send them home. some of them were back in 2 days. You know, they'd come right back in and start a new cycle. They weren't ready to leave, or they went home and failed and immediately came back. So no matter what you did, the thing that I learned from that is, as a therapist, you just need to have the best intentions possible, put out the best effort you can, and realize that you can't fix everyone. You know, you can help them, you can brighten their day, you can give them the information they need. What is it? You can lead a horse to water, but you can't make it drink. It's kind of like that. In a situation like that, you can't, nothing you do is going to make or break whether or not they maintain sobriety. All right, that's the end point. Let me go back to that and see if there's anything I want to bring up. On all of these from this chapter, as far as looking at testing stuff down the road, know about each one of the developmental disabilities we talked about. You know, what is autism? What are the signs and symptoms? What are things that we can do with them as recreation therapists? What do they generally like? What do they not like? Cerebral palsy, what's going on with that? Down syndrome, what is the cause of it? Spina bifida, know the different types of spina bifida, and we talked about that as we went through. But those are the kind of things that we'll be looking at moving forward. I've talked a little bit down here at the bottom. It's talking about age-appropriate interventions, and I'll go back to the NMRC again. I keep taking you guys there because I worked there so long. But you work with clients there who have intellectual disabilities. So they are 45 years old, but they operate on a 9-year-old level. That's their functioning level cognitively. So they want to, you know, carry around a doll. They want to watch cartoons and things like that. And there's a fine line between what we're able to do as recreation therapists of giving them what they want and making sure that we're leading them to do age-appropriate things. Reason being, at almost all facilities where you would work in these settings, you have people that would come in, they're called surveyors, things like that. They come in every year. They're going to check to be sure that what you're providing as services, whether not just recreation therapy, they're looking at nutrition, they're looking at the nursing, they're looking at psychologists, making sure that everything is being done in safe manners and in the appropriate manners, and that we're providing active treatment for the clients, which is we're actually hands-on working on goals and objectives as therapeutic recreation specialists. You're not rolling out a ball and saying, okay, go play soccer. Y'all kick the ball around, have fun. That's not active treatment, and that's not what these people are looking for. When the surveyors come in, they also do not, and I can tell you this from seeing it, if they see a 45-year-old intellectually disabled client walking around with a baby doll, they are going to ask you why. And, you know, there may be a good reason, and it's maybe a situation where they would understand what's going on. But I'm just saying that's where age-appropriate interventions come into play, is that you have to answer for some of the things that you do. If they're not age-appropriate, you could almost get in trouble for that. Okay, we talked about precautions that need to be taken, or contraindications, which are things that you just do not do with the different types of developmental disabilities. So kind of note that question potentially. And then we talked about things that we would work on, you know, what goal areas for each specific group. That was covered in the slideshow as well. So I think that we've covered this chapter. I think we'll stop for today. I thought about possibly going into the next one, but it's a Thursday and everybody looks a little tired, so we're just going to call it, and we will jump into. However, I'll go ahead and give you fair warning. I don't want to get too far behind. We're going to go into chapter 10 next class, and then we're going to jump right on in. When we finish it, if we finish, we'll go straight into chapter 8. And I know I'm going all over the place with the order, but it doesn't really matter as long as we get what we need to cover. So we'll hit 10. If I can get 10 and part of chapter 8 done, that's what we're going to do next Tuesday. So that being said, you may be here the whole time that day, but you're getting out about 30 minutes early today. So you guys have a great weekend. Oh, sorry. Let's make it 25 because I got a couple things. Remember you guys sent in your leisure experience papers? I hope that you guys are trying to stick to the things that you said you were going to do. We should be able to open a yoga facility for sure. A lot of you guys chose yoga. Some surprised me actually that chose that, and that's cool. That was probably the most common choice. I didn't really know what to expect, but I think that that's good. This is basically just a little pep talk. Y'all try if you haven't been doing it, try to do what you said you were going to do, because you're going to have to turn something back in November telling me how it went. So hold yourself accountable. If you haven't been doing it, see if you can do it from here going forward, because it's meant to be something for you that will help you feel better during this time of craziness. You know, if it's walking every day, try to do it. Also, one other thing, and this is actually comical to me, and I'm not going to call anybody out, but this is just something to watch out for. In the last class, I was going to meet with a student afterward, and so once I told everybody bye, we logged off, and I watched everybody click, 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 get off. And there was a few of you that were clearly not still at your computer, but you were still logged in without your camera on. So don't do that. If you got to leave, don't think you're outsmarting me because we ended up catching you. But that to me was just a little comical. Don't just come and click it on and leave. If you're going to do that, you might as well not even fool with it. So I want you guys to do well. I try to give you every opportunity that I can to make that happen. Also, I'm not going to say a name, but I have one person I've tried to get in touch with. You still need to do the midterm. If you want to take it, you need to take it ASAP or you will not be able to. So if you're here right now, and I don't remember whether I saw you come in or not, if you're here and you have not taken the midterm, go take it. Also, if you have not done the leisure experience paper, go write it. I will give you some credit for both of those things. It would be worth your time. For the rest, all the rest of you, I just wasted 1 minute of your life because you didn't need to hear that. So anyway, thank you guys. I won't keep you any longer. You guys have a wonderful rest of the day and a good weekend, and I will see you Tuesday, okay? See y'all.
Adios.
Later, peeps.